Hi, I'm Tim Spencer and welcome to today's session. I'm really excited to be speaking to you today, and this session is on catheter-associated thrombosis and the impact of catheter vessel ratio. We'll be doing a general review of current literature that focuses specifically on thrombosis and catheter vessel ratio and the impact that these have with one another. These are my disclosures. I'm currently the Principal Director and CEO at Global Vascular Access, an international consultancy company. I'm a consultant for Fujifilm Sonosite Incorporated. I am the President for the World Congress on Vascular Access, or WCOVA, as many people know it. I'm also the Associate Editor for the Journal of Vascular Access and manage the arterial section of the journal. I have no other membership or affiliation conflicts of interest with other professional organizations or companies, and I have no stock or shareholding conflicts to declare. The objectives for this session are to do a brief review of vessel health and preservation strategies, which is an underlying focus on many vascular access initiatives. Review the factors of catheter-associated thrombosis. Identify the importance of catheter vessel ratio and its importance and relationship to catheter-associated thrombosis. We're going to review the impact of blood flow with current catheter vessel ratios. And also we're going to look at the current evidence on catheter vessel ratio and its importance. Vessel Health and Preservation, which was initially published in 2012 and has been updated in a number of publications most recently, is a model that is applied to vascular access, focusing on the administration of IV medications and treatments that structure evidence-based practices within 4 quadrants of both medical and nursing care. These areas focus on assessment and selection, the insertion, the care and management, and the evaluation of vascular access devices. The aim of the Vessel Health and Preservation model and pathway is to improve the quality of care, reduce risks associated with vascular access devices, but also increase patient satisfaction and the overall efficiency within healthcare resources. The model is represented in a pathway within the quadrants of care that follow the patient treatment process. This is a graphical example of the Vessel Health and Preservation model. As you can see, the 4 different quadrants. Number 1 being the assessment and selection, and some of the criteria listed underneath. Quadrant 2 focuses on insertion, with several items that are to be considered as part of the assessment process. Quadrant 3 focuses on management, which is looking at daily assessment, the use of ANTT, identifying complications and managing them, and Quadrant 4, which is focusing on the evaluation, looking at patient outcomes, following complications, looking at staff competency, and looking at formal processes of product evaluation and education and gaps that allow for the introduction of new products. This slide provides an example from the United Kingdom on their vessel health and preservation strategy from around about 2020. And it highlights a number of specific areas focusing on the 4 quadrants around the right decision tools and the secondary questions that clinicians often ask to help optimize device selection and management in patients requiring vascular access and infusion therapy. Some of the key points around vessel health and preservation model are that comprehensive device assessment, selection of the most appropriate vessel, and the insertion site location require an ongoing commitment to clinician education, facility policy development, and the use of specialized clinicians, namely our vascular access specialists. Assessment of patient history, comorbidities, contraindication and risks, available vessels, the diagnosis and the duration of factors that often are the determining factor for choosing an appropriate device through the most qualified inserter. Ensuring that the insertion is performed by trained and qualified clinicians with ultrasound skills are directly relational to reducing post-insertional complications. Device management includes the insertion site, the dressing and securement, but also the device function prior to every infusion. So this improvement of care is impossible without the need for an established process of evaluation. This is where vessel health and preservation is a strong contender to impact all of these factors. Catheter-associated thrombosis has serious implications, particularly around the loss of vascular access devices, development of pulmonary embolism, which can be a life-threatening complication, the opportunistic effect of recurrent venous thromboembolism, which may influence and impact future vascular access choices and therapies, along with infectious and post-thrombotic syndromes. Monitoring catheter vessel ratio is an essential strategy for clinicians to make sure that they're utilizing an appropriately sized device in an appropriate size vessel, meaning that what we're establishing is a relationship of appropriateness between the two devices. By selecting a smaller device and allowing for a greater catheter vessel ratio, this allows us to potentially improve blood flow through the vessel around the body of the catheter, which may improve flow dynamics within the vessel and help reduce the buildup of fibrin within the vessel and help reduce catheter-associated thrombosis. This preliminary study by Van Ruden from 2005 determined that most catheter-related DVT or catheter-associated thrombosis are clinically silent. And looking at the representative data that's on the screen in this pie chart showing that 60% of catheter-associated thrombosis is asymptomatic or silent against 40% that show symptomatic clinical indicators is important because ongoing literature has reinforced that there are a number of complex and multifactorial episodes that are associated with risk factors. But looking at the literature that has been published since this publication has shown that the relevance and the incidence of both symptomatic and asymptomatic catheter-associated thrombosis hasn't drastically changed that much. So what are the causes of thrombosis? We know that thrombosis with use of long-term centrally inserted central catheters is a serious complication that causes morbidity, which includes deep vein thrombosis, but it also impacts the development of pulmonary embolism, or PE, and post-thrombotic syndrome. Thrombosis of any catheterized vessel is a potential complication. So regardless of the type of device that is inserted, whether it be a peripheral IV, whether it be a midline catheter or a PICC, a centrally inserted central catheter, including acute hemodialysis catheters, every single catheter is at risk of causing catheter-associated thrombosis amongst our patient populations. Catheter-related thrombosis is also more common than infectious complications, as proved in some of the literature, especially when smaller veins of the upper extremity are considered. So when we think about complications associated with vascular access devices, a lot of our focus over the last several decades has been very much so on the infectious complications. However, the risk of VTE or catheter-associated thrombosis has been on the rise over the last decade significantly because of the increased use, particularly of PICCs, amongst various patient populations. And we'll go into this a little bit further throughout the presentation. This slide focuses on a number of risk factors around thrombosis. And as you can see, it's broken down by patient groups with the risk of DVT prevalence in percentage on the right-hand side. Some of the earlier studies have reported that symptomatic catheter-associated thrombosis is as high as 28%. There's even been some reports as high as 65%. But a lot of the more recent literature has shown a lower incidence of around about 5%, up as high as around 10%. But this can be very independent of the type of study that is being done and also the patient population. Studies have also suggested that catheter material, the tip position, infection, multiple attempts at previous catheterization, which obviously cause vessel-related trauma, and other influences may impact catheter-associated thrombosis. Medication has been reported in the literature over many years as playing a potential role of thrombotic influence, particularly around the constitution of particular medications that influence pH and osmolar values, which has a direct impact on the endothelial layer of the vessel wall. This table is a list of suggested risk factors in association with catheter-associated thrombosis. And some of the intrinsic factors are obviously the CVC type. So PICC has a greater risk than a CICC than it does an implanted port. Same thing applies to tip location, CVC diameters. A triple lumen, a quad lumen has a much significant impact on blood flow and catheter-associated thrombosis than a single or a double lumen catheter. So the less number of lumens and the smaller external diameter is an important consideration if we want to reduce our catheter vessel ratio. The insertion site, femoral, subclavian and jugular. A number of literature publications have shown that there's a higher incidence of catheter-associated thrombosis in the jugular approach as opposed to femoral or subclavian, but there's mixed literature around the optimal site, and a lot of the decision around site insertion choice should be based on a number of patient considerations, which, going back to vessel health and preservation, would help strategize a lot of those issues. The site of insertion, left or right side, well, that's pretty self-explanatory. Coming from a left approach, particularly with a PICC, requires more curvature and more turns within the vascular system, so there are more contact points that the catheter external wall comes in contact with the internal wall of the vessel. Duration of catheterization, multiple CVC or catheter insertion attempts, and extrinsic patient factors like cancer, etc., are all impactful against catheter-associated thrombosis. Tumor type, metastatic disease, chemotherapy, previous thromboembolism history, and known thrombophilia, whether it be through factor V, Leiden, or prothrombin gene mutation, these have all been shown in the literature to impact catheter-associated thrombosis. This study from 2023 in Japan focused on risk and prognosis of patients with central venous catheterization and looking at upper extremity deep vein thrombosis. 95.5% of these cases were directly related to central venous catheters for either infusion therapy or dialysis, and about 4.5% were due to the insertion of a pacemaker or a Swan-Ganz catheter or thermodilution catheter for monitoring of cardiovascular diseases. Pulmonary embolism was reported in about 10.5% of patients, and as far as symptomatic cases go, such as swelling and pain in the upper extremity, almost 43.5% of patients had some form of symptomatic complication. You can see with the screen capture from table 2, the proximal site of the DVT, the highest site that represented a catheter-associated thrombosis was the right internal jugular vein at 35.3%. Now, this may be representative because it is the most commonly cannulated vessel for central venous access because it is a straight path to the SVC. It's used routinely for percutaneous central catheterization, but also for dialysis in both acute and long-term dialysis catheter insertion. The number of sites obviously reduce with the left IJ, left subclavian, right subclavian as it moves further down to the right and left upper extremity, which show much lower results as far as vessel choice, but the impact is still very relevant depending on the type of device that's being placed. So when we review some of the incidence reporting from a number of publications, there was a 2007 systematic review that looked at the incidence of symptomatic CVC-related DVT in adults and reported that it varied between 0.3 and 28%, whereas the incidence of venography-based cases that were assessed looking specifically at asymptomatic DVT, that the ranges were from 27 to 66%, significantly different. When we compare the rate of PICC symptomatic thrombosis, a lot of the rates have been reported anywhere from 3 to 20%, whereas asymptomatic thrombosis has been reported as high as 62, and in some more even recent literature as high as 65%. Pulmonary embolism, on the other hand, is reported in about 15 to 25% of cases of patients with CVC-related DVT. And although the thrombosis rate is high, only about 1/3 of that patient population become actually symptomatic. However, CVC-associated thrombosis can result in significant clinical symptoms, loss of catheter function, which obviously requires replacement, a higher risk of infection, post-thrombotic or post-phlebitic syndrome of the upper extremity, but also increased risk of pulmonary embolism and greater costs to the patient and the facility. The medical inpatient and thrombosis study in 2015 was a case control study in which all cases of venous thromboembolism at a single institution between 2000 and 2009 were matched with patients who did not have venous thromboembolism. Interestingly, central catheter use was associated with a 14-fold increased risk for upper extremity DVT, and PICCs were associated with a higher risk compared to CICCs. When you look at the cumulative indices for upper extremity DVT, patients with no catheter had a risk of 0.2 per 1,000 days, or per 1,000 admissions, I should say, 4.8 for CICCs, and 8.1 for PICCs. The difference between no catheter and a PICC was a 40.5-fold increase in risk of DVT. That is huge. So understanding the impact that PICCs have at increasing upper extremity DVT is very relevant. Now, admittedly, this study was from 2015, which is now 10 years old. So we need to understand what is the change. Now, PICC use has increased in the last decade. So does that mean our cumulative indices for patients with no catheter to having a PICC has increased even further? We don't know. And obviously more research needs to be done in this field. But it's important to understand that 10 years ago, there was a 40.5-fold increase in upper extremity DVT in PICCs, and usage of PICCs was far less than what it is today. A narrative review by Baumer and Kreuziger in 2017 determined that overall catheter-associated thrombosis represented approximately 70% of all upper extremity DVTs and about 10% of all venous thromboembolism. Given the recent improvement with insertion techniques, particularly focusing on ultrasound-guided insertions, dedicated vascular access teams, the use of vessel health and preservation as a pre-assessment strategy, the evolution of catheter materials such as antithrombogenic and hydrophilic catheters, the overall risk of catheter-associated thrombosis has slowly decreased over time. That is what we would think. However, recent literature has yet to prove otherwise. Study by Ellis et al. In 2020 studied the rate of and risk factors of the development of symptomatic catheter-associated thrombosis. 4,920 central catheters were inserted in 3,130 patients, and their overall risk of catheter-related thrombosis was 3.6%, and it developed after a median of 12 days following device insertion. So within 2 weeks of device insertion, at least 3.5 to 4% of patients developed symptomatic thrombosis. What they did also determine that was an age less than 50, PICC lines and prior catheter-associated thrombosis were associated with the highest catheter-related thrombosis rate. Cancer and the type or subtype of cancer and insertion site were not predictive of thrombosis in this particular review. A recent meta-analysis in 2022 on risk factors associated with catheter-associated thrombosis showed that pooled results of both venous thrombosis, cancer, infection, and use of a multi-lumen catheter all significantly increase the occurrence of catheter-related DVT. The authors found no significant correlation between gender, congenital heart disease, a bedridden state, sepsis, mechanical ventilation, anticoagulation therapy, or a left side insertion against catheter-related venous thrombosis. More recently, an observational cohort study that was published in Thrombosis Research in 2023 by Amit Bal, a physician from Michigan, demonstrated an overall DVT rate of over 3,000 midline catheters was approximately 4.7%. And it demonstrated that 5 French midlines had a significantly greater risk of thrombosis against 3 and 4 French catheters with a statistical significance of 0.001. They observed a similar trend in sub-analysis of midline catheters with a documented catheter vessel ratio. They performed multivariable logistic regression analysis, which identified female gender, a history of thrombus, the use of vesicants, midline catheter that was placed in either the brachial or the cephalic vein, and a 5 French catheter all increased the odds of developing a catheter-related or catheter-associated thrombosis. This study from the Journal of Clinical Anesthesia in 2024 looked at the incidence and onset of central venous catheter-associated thrombosis in critically ill surgical patients. It was a prospective observational single-center study that was done in Germany, and the findings from this study showed that most catheter-related thrombosis were asymptomatic, and patients with CVCs are rarely screened for catheter-related thrombosis in routine clinical practice. Almost all of the CVCs were inserted into the internal jugular vein in these patients, and they all developed asymptomatic catheter-related thrombosis within the first few days of catheterization. The incidence that was reported between medical and surgical patients ranged from between 6 to 56%, and that's a significant increase. While largely their commentary about the fact that patients were rarely screened for clinical thrombosis, there has been a number of recent publications that have focused specifically on the use of ultrasound in the pre-insertion phase, the intra-insertion phase, and the post-insertional phase to monitor for the development and also resolution of any thrombosis. Ultrasound is a non-invasive technique and can be very useful for the bedside clinician to determine thrombosis, whether it is increasing or whether it's actually resolving. Just a quick review of Virchow's triad, which was formulated in the mid to late 19th century. It still forms the basis for the current theory of thrombus formation, and it defines 3 essential core relationships. That's hypercoagulability, vascular damage, and venous stasis. A number of these strategies as vascular access specialists we're all very familiar with. Vessel wall damage and endothelial injury causes vascular injury. Alterations in blood flow such as venous stasis, particularly in our critically ill patients where it's very difficult to move them or they're being nursed in a prone position, increases the risk of venous stasis. And then we have such incidences of hypercoagulability, where there are changes in the chemical composition of the blood through cancer and a variety of other comorbidities and diseases. These effectors are all influential in the development of thrombosis, and the relationship to any catheter-related complications can be associated back to Virchow's triad. Obviously, central venous catheters can affect Virchow's triad through stasis, but also through direct vascular injury. However, the recent increase in the presence of catheter development of antithrombogenic material surfaces have created an opportunity to investigate the impact that these both antithrombogenic and hydrophobic materials have in reducing the opportunity to develop catheter-associated thrombosis. Obviously, in many cases, there's a number of situations where patients specifically fit all three core criteria for thrombosis. And if you think about it as a clinical example, a patient that has cancer that is in the intensive care unit on critical therapies who requires multiple vascular access devices satisfies all three components of Virchow's triad, therefore increasing the potential risk factor of developing a much significant and higher risk of catheter-associated thrombosis. So if we think about the science behind decreasing the venous diameter, and that can be from a number of particular ways, and that through literature we've seen that there is no actual change in the flow rate until it reaches a critical point. There is pressure that is behind the narrowing of vessels, and obviously when this happens, fluid will and can find another pathway to create collateral circulation and look for an alternative pathway if there's an obstruction. And that obstruction could be thrombosis, it could be the catheter itself, or it could be a combination of the two together. But what happens is that as we have a decrease in the catheter vessel ratio, because we have all of a sudden a narrowing of the vessel, but an also potential increase in the external diameter of a catheter because there is a thrombosis that is attached to the external component of the catheter wall, this slows blood flow through that narrow region. And this promotes stasis behind that. Even though there's an increased pressure, it can cause endothelial damage and shearing. It's affected also by coagulation, but also by platelet activation as well. So a number of these factors all contribute to the overall effect of catheter-associated thrombosis. And catheter vessel ratio can impact that flow and pressure through the vessel. And therefore, from this picture, you can see with the thumb over the end of the hose, if we obstruct flow at a certain point, we get a buildup of pressure behind the thumb, but we also get a risk of increased flow or pressure on the other side as blood or fluid is forced through that narrowed stricture. So this is an example of a PIVC with an associated thrombus. Now, as you can see, there is potential obstruction of the vessel, which may reduce blood flow, and that disturbance in blood flow can encourage thrombosis. So this is essentially a 20 gauge peripheral IV in the cephalic vein, and this image was taken 24 hours after insertion. And as you can see, there is extension of a thrombus from the catheter tip beyond into the vessel, and that can lead to potential further complications as regards to catheter-associated thrombosis, particularly if it attaches to the endothelial wall. We did discuss some of the catheter-related factors earlier, but we didn't cover all of them. And certainly from the research that's been published in the last several decades, left-sided insertions, multiple insertions attempts, a catheter tip that is located proximal to the distal SVC or the cavoatrial junction, and the type of catheter material are all influential at changing the catheter-related factors around catheter-associated thrombosis. The number of lumens, which obviously increases or decreases the external catheter size, prior catheterizations at the same puncture site, which obviously is more trauma related, prolonged catheter dwell time greater than 2 weeks. Yet, interestingly, some of the research has shown that short-term catheterizations have just as much increase in risk of catheter-associated thrombosis as opposed to some of the more longer term. And some studies have actually shown that there has been resolution of catheter-associated thrombosis beyond 20 to 30 days. Now, there's not enough evidence to say that this is a commonplace occurrence. However, there has been anecdotal reports that on initial diagnosis with ultrasound that there was a catheter-associated thrombosis and that it was resolved beyond 20 to 30 days. So there's more room for investigation, particularly around the resolution of catheter-associated thrombosis. So these are interesting factors that we need to consider as clinicians as we progress through our patient populations and ensure that catheter-associated thrombosis is being monitored accurately. Obviously, catheter-associated or catheter-related infection and sepsis and reverse taper catheters also have documented impact on catheter-associated thrombosis. Catheter design can also be potentially influential in thrombosis development. If we think about the function of a reverse taper catheter, essentially we're using a larger portion of a catheter body that is essentially being inserted into the vessel. So while the lid stock may say that this is a 5 French double lumen catheter, the reverse taper component may be almost 1.5 to 2 Frenches increased in size. And if clinicians are inserting this reverse taper component into the vessel, their catheter vessel ratio can drastically change. And while the INS standards say we should be using less than 45% catheter vessel ratio, for those clinicians that use reverse taper catheter that insert to the 0 marker, you need to make sure that when you are assessing catheter vessel ratio that you're using the largest portion of the documented catheter size. So for example, a catheter that is a 5 French in its non-tapered component but increases to a 7 French at its reverse taper must be calculated off the 7 French size, not the 5 French size. This is a common misconception for clinicians that use reverse taper technology. Straight taper or non-tapered technology, it doesn't matter because the catheter external diameter doesn't change. Therefore, catheter vessel ratio calculation will be related to the overall length of the catheter and size. But a reverse taper component is different, and this needs to be taken into account when clinicians are assessing for an appropriate catheter vessel ratio. This is an example of several commonly used catheters in clinical practice, showing the difference between a non-tapered and reverse taper and the size increase. So the top image shows a non-tapered catheter in 5 French, and as moving down, we can see that there's an increase in catheter size from 4 French to 6 French in the secondary image, and the third and fourth images both increase in 2 French sizes from a 4 French to a 6 French and a 5 French to a 7 French. For clinicians that do use reverse taper catheters, it's important to remember that a 7 French reverse taper component is the same size as a triple lumen 7 French CVC. So the question is, would you insert a 7 French triple lumen catheter in a patient's upper extremity if you knew that the size of the catheter was influential? This is a common dilemma amongst clinicians, and it's something that we need to make sure that clinicians think about when they're using PICCs, because a PICC is still a CICC, it just happens to be inserted in the upper extremity. A paper from 2021 by Bertoglio, published in the Journal of Vascular Access, focused on reverse taper and sheath relationship, but also tied in the fact that there was potential for catheter-associated thrombosis from these two common issues. And what they found that reverse taper technology catheter wouldn't fit through a standard sheath. So manufacturers had to manufacture a larger sheath so that the reverse taper catheter component would be able to fit through the sheath. What was then identified was that patients and clinicians had to use a scalpel blade to create a skin nick because the dilator was too large to go through the soft tissue and was difficult to insert. So a skin nick was required to facilitate an easier entry of the dilator into the vessel. This, in conjunction with use of a scalpel blade, causes trauma to localized tissue and potentially for the vessel itself, increasing the risk of bleeding, which increases the risk of infection, which increases the risk of thrombosis as well. The negative effect of the reverse taper was that it would plug the hole and reduce the bleeding, which was, in many clinicians' eyes, a suitable offset. However, the larger component of the reverse taper was inserted into the vein, and while it obstructed bleeding, it also obstructed flow around the catheter at the insertion site, therefore increasing the catheter vessel ratio to a much larger ratio and preventing adequate blood flow around the catheter. This eventually led to the potential for larger introducers that were inserted into vessels to allow for the reverse taper component, but it also caused major trauma to the vessel, particularly the vessel wall and the endothelium, and this may have increased the risk of potential catheter-associated thrombosis. This is something that clinicians who use reverse taper catheters must factor in to their insertion, but also their assessment phases of doing vascular access for their patients. Arm circumference. It's a bit of a latent sign for catheter-associated thrombosis, and although clinicians have been measuring the circumference of the upper arm for many, many years, I even did it when I was a student 35 years ago, it wasn't a very sensitive measure that there was a problem. A lot of the issues around using arm circumference are very latent responses to upper extremity DVT and the associated swelling of the limb. And while the INS standards of practice have said this is how you do it, measuring arm circumference to look for edema and signs of DVT may be associated with catheter DVT, but once you start to see a significant change in the external diameter of the upper extremity, the damage has already been done. There is already a thrombosis that has well established itself within the vasculature and is causing associated problems. So while arm circumference may be considered a endpoint to measure, it has to be done routinely. It has to be done in the exact same position, but it also doesn't show signs of problem until well after the problem has already developed. When we think about catheter vessel ratio and some of the early statements, in 2007, the Infusion Nurses Society standards recommended that the target vein for vascular access must be suitable to accommodate the catheter. A very indistinct and generic approach to a description, and pretty straightforward in that particular instance because there was probably no real evidence around at that time. In 2011, the standards of practice subsequently were updated, which to include the vasculature shall accommodate the gauge and length of the catheter required for prescribed therapy. And what was really missing from their recommendation was an actual unit of measurement because there was still inconsistency amongst clinicians on what was to be determined as the most appropriate catheter vessel ratio. And if you look at some of the very early literature and some of the online forums that were around in the early 2010s, many clinicians were still using a 50% catheter vessel ratio because it was easy to calculate. Catheter vessel ratio was finally addressed in the 2016 INS Standards of Practice, and their recommendations at the time were to use a catheter vein ratio of equal or less than 45% in adults. However, this statement was based upon one study of a small number of patients, less than 100, of healthy volunteers, which doesn't necessarily represent the majority of our patient populations. However, it did provide a basis of understanding and appropriateness that using vein diameter and measuring it with ultrasound before insertion was an important strategy that should be utilized by clinicians to help determine a most appropriate catheter vessel ratio. They did say that there was a study that was published that 6 French triple lumen PICCs were stopped before completion due to unacceptably high rates of DVT. That was the Treratola study from 2011, I think. But it was important because this established the foundation of future research, particularly around catheter vessel ratio and any associated catheter-related thrombosis. The Infusion Nurses Society updated their standards of practices again in 2021, making reference to catheter vessel ratio prior to insertion, and that it should be no more than 45% ratio. Once again, it was basing the evidence on published literature that had been done previously, and to use the smallest catheter in the largest possible vessel. Clinical signs and symptoms that they recommend to look for was pain, edema, erythema to the extremity, shoulder, neck, or chest, and other classic signs of catheter-associated thrombosis. Catheter vessel ratio was also addressed in the INS Standards of Practice that was published in January 2024 in 4 different standards within the document. Standard 21, looking at vascular visualization, and once again, ensuring that a catheter vessel ratio was less than 45%. Standard 25, which is vascular access device planning and site selection. Standard 32, vascular access device insertion. And Standard 50, looking at catheter-associated thrombosis. Once again, in all of these standards recommending that the catheter vessel ratio be less than 45%. A study by Adam Fabiani that was published in Heart and Lung in 2023 focused on catheter vessel ratio at the tip level and not the catheter type as a risk factor for catheter failure. The study looked at a retrospective study of both polyurethane midline and long peripheral catheters of 240 patients that were included. The objectives were to compare catheter failure associated between polyurethane midline catheters and long peripheral catheters, and considering the effect of catheter vein ratio at the tip location. What this study found was that the risk of catheter failure was strongly associated with a catheter vessel ratio greater than 45% at the catheter tip level, irrespective of having used a polyurethane long peripheral catheter or midline catheter. Looking at the Cox regression of catheter failure on the study variables from the Fabiani study, a higher catheter vessel ratio may represent a critical point for the risk of complications, and an indwelling catheter device may induce slower and turbulent blood flow. Therefore, higher catheter vein ratios there is a higher expected effect of decrease in blood flow. Moreover, a lower blood flow rate allows slower dilution and transport of medications administered into the vessel, thus prolonging contact of the drug with the vessel wall, which may cause damage to the endothelium, therefore increasing the risk of complications, particularly catheter-associated thrombosis. There has been published evidence that shows that catheter-associated thrombosis is related to the external catheter size within the intraluminal space. The increase in the number of PICC lumens results in a larger differential gauge size, and this has been considered as a factor independently associated with an increased risk of DVT. And while there has been significant increased use of PICCs over several years, also, as we previously mentioned, has the increase in incidence of upper extremity DVT. And a conglomerate of the reported associated rates associated with PICCs range anywhere from 0 to 20%. Now, a number of these papers are probably older papers from 2011 to 2014. However, with that increase in the use of these devices, particularly PICCs, there's potentially an increase in catheter-associated thrombosis that is directly associated with the use of these particular devices. A systematic review and meta-analysis published in 2022 by Ball et al. Was the first meta-analysis that quantified pooled symptomatic DVT rates by common PICC sizes, ranging from 3 to 6 French. Previous literature had evaluated DVT rates that were a combination of symptomatic, asymptomatic, or both, making it challenging for an accurate representation and evaluation. What they did find from their research was that larger PICC diameters were associated with a greater risk of symptomatic DVT. Well, that doesn't surprise anybody really, because a lot of the literature has already produced these sorts of results and these sorts of findings. However, strong high-level evidence such as systematic review and meta-analysis is really required to really get an accurate take on where we fit from an evidence-based approach to reducing catheter-associated thrombosis. And this is important because there's a lot of observational studies that report different rates, but there's a lot of variables that can't or haven't necessarily been evaluated. A systematic review and meta-analysis allows for a much more high-level overview of this sort of research, and certainly creates a much more focused result, which is more impactful for clinicians to take into consideration when they're looking at changing their clinical practice. While the study results align with the Infusion Nurses Society standards of practice, it did describe that DVT risk is higher with larger diameter PICCs. And given the risk of associated DVT in related to diameter sizes, the recommendations here is that clinicians should deliberately assess this variable prior to insertion of a device and try and balance the risk of thrombosis, yet being able to deliver the most appropriate device to deliver the type of therapy that is required. And certainly, clinicians should always try and choose the smallest diameter vessel with the fewest number of lumens for the anticipated type of therapy. And this has been a common discussion point for many, many years. But once again, this systematic review and meta-analysis really highlights the importance of this decision-making process and the impact that it may have on our patients. So an interesting question, particularly with ultrasound, is how do we measure the vessel? Do we measure from the top to the bottom, or do we measure from side to side? I've spoken to numerous experts on this, and most of them agree that measuring from side to side is the more accurate measure that should be taken of a vessel. Why? Question mark. Top to bottom is influenced by the superficial nature of the vessel, but it's also heavily influenced by the downward pressure that the clinician has on the probe on the surface of the skin, therefore making the top to bottom measurement smaller than what it actually is. One of the misconceptions around this is that if you look at the image on the screen, you can see that the arrows going up and down and left to right are of different length. But what doesn't change is the cross-sectional area of the vessel within that circle. Because no matter whether you squash the vessel from a circle to an oval, from top to bottom or left to right, the internal measurement based on area doesn't change. While there are different camps of thought on which is better, a linear measurement or an area-based measurement of catheter vessel ratio, essentially it doesn't really come down to any difference because they are just two different units of measurement. So either measurement is appropriate as long as you are using the same method of measurement every single time. They reflect the same thing, and it's important to make sure that when you are documenting catheter vessel ratio, that you are clear in how you have obtained your catheter vessel ratio measurement. So when we interpret the guidelines, if you look at the INS standards of practice, they recommend less than 45%, but previously it was a range. It was 33 to 45% or less than 33%. When we look at area has a different number. So what happens between 33 and 45% from a lineal measurement corresponds to a 10 to 21% in area-based measurement. So it's very important that whether you use a lineal measurement or an area-based measurement, that it's clear in your description and that you understand and portray the importance of the different type of measurement that you are using. Because if people or clinicians start mixing lineal with area, it becomes very confusing. And that's what we don't want to do, is create confusion. A common question for clinicians is, how do I convert French to millimeters so that I can do my mathematical calculation? It's pretty easy. Catheter French size is multiplied by 0.33, and that gives us the outside diameter of the catheter in millimeters. So current vessel measurement is expressed in millimeters or centimeters on an ultrasound, and it's important to be able to make sure that the units of measurement of the catheter equal the same units of measurement as how we measure the vessel on the ultrasound machine, whether it be in millimeters or whether it be in centimeters. If we look a little bit closer into using area as a unit of measurement, we have to focus on what we have done in the past. And the rule of thumb was a common unit of measurement, although it had never been verified through clinical research, was that a 4 French catheter should be placed in a catheter no smaller than 4 millimeters in diameter. Now, this is the 1/3, 2/3 catheter vessel ratio that many people have talked about over the years. The rule of thumb works out to be about 10.89% or just under 11% when we convert it to area. So once again, we're showing that there are two different units of measurement. They both measure the same thing, but they're just different numbers because they're different units. The rule of thumb calculates to be likely more effective at associated risk reduction strategies for catheter vessel ratios because it's easy to calculate. 4 French catheter shouldn't go in a vessel smaller than 4 millimeters. A 5 French catheter should not go in a vessel smaller than 5 millimeters. A 6 French catheter should not go in a vessel smaller than 6 millimeters. It works on its simple process because it's a 1/3, 2/3 catheter to vessel ratio. It's very simple and it's also very effective. The area rule of 10 to 21% is different in number, but the concept is exactly the same. This is a drawing that I did a number of years ago, really to highlight the difference between lineal and area measurement, because where the X's are not considered or taken into account when you do a lineal measurement. You're just measuring across the vessel. And in this case, we're measuring from north to south. Now, while this may not necessarily be representative of what I just said before, where we should be measuring from left to right, the point is to be that if you measure from one side of a vessel to another, there are several aspects within the vessel that are not considered or taken into account when we take a lineal measurement. Cross-sectional area of the vessel takes into account all those areas where the X's are. And as you can see in this particular instance, the catheter or the circle takes up 50% of the catheter space based on the lineal measurement across the middle of the vessel to the external catheter wall on the left-hand side. Now, that's not necessarily representative of an area-based calculation because it misses out on a lot of information that's not being taken into account. And this is one of the differences between a lineal and an area-based measurement, because area focuses on the cross-sectional area differences between the internal lumen of the vein and the external lumen of the catheter. So I hear many of you ask, so which unit is best? What do we use? What do we choose? It doesn't really matter at the end of the day. I think catheter vessel ratio is more important, that clinicians are actually measuring the vessel to understand what the relationship is between the size of the catheter that they may be choosing or that they have available to the size of the vessel. Remember that some hospitals only have one type of PICC line, and that might be a 5 French double lumen, for example. Not every vessel will be suitable for a 5 French double lumen PICC, which is one of the reasons why it's important, one, to measure the vessel, but two, to have at least several options of catheter choices that give you the ability to choose the most appropriate device for the patient, for the therapy, based on their assessment. How do we measure catheter vessel ratio? Well, there's a number of ways that we can do that, and we'll get into that a little bit later. But a lot of more modern ultrasound machines actually give us a number of options to be able to measure the vessel accurately. We can use a caliper, there's an elliptical tool, or there's even a trace option. Trace option is probably a little bit more difficult to utilize, but certainly the caliper and the elliptical measurements are very good because they allow you to be able to measure both diameter and the cross-sectional area at the same time. So these can be performed relatively easily, and certainly the use of a quality measurement tool is something that is very much encouraged, particularly in the vascular access realm. And one of the things from our paper in 2017 was what we were trying to encourage was clinicians to make sure that they're measuring the vessel accurately. So if we have greater accuracy, we have greater data, we have better monitoring, and that improves for greater patient outcomes. And I think at the end of the day, that is what the intent is. When the difference between a lineal and an area measurement is just a unit of measurement, but it's the outcomes at the end of the day, making sure that we're choosing an appropriate device based on the size of the vessel and the size of the catheter that we have available for use is really taken into account by clinicians. This table from publication in 2017 shows a comparison of catheter vessel ratios between 33 and 45% and the changes in external diameter based on catheter French sizes. So as you can see, current guidelines say that the catheter should never take up more than 33% or 1/3 of the internal vessel diameter, although the INS standards of practice say less than 45%, but just increasing from 33 to 45% is a 26.7 increase in external catheter diameter. That's a significant increase. So that's over a quarter of the size of the catheter is increasing if you just go from a 33% catheter vessel ratio to a 45% catheter vessel ratio. So stop and think about that for a minute. Just by changing the catheter vessel ratio allows an increase of up to over 1/4 of the size of the external diameter of the catheter. So in 2017, a publication came out talking about catheter vessel ratio definition and that there wasn't really a clinical definition of catheter vessel ratio that had been defined in the literature. And this paper defined catheter vessel ratio as the indwelling space or area consumed or occupied by an intravascular device inserted and positioned within a venous or arterial blood vessel. It's a pretty straightforward sort of description. However, it's still not routinely referenced in standards or guidelines, even though it's a very clear description and accurate representation of what catheter vessel ratio should be, because it defines both either a lineal or an area-based approach without specifying necessarily a linear or area-based approach. It's talking about how much space is occupied within the vessel by the catheter itself. This study from 2017 focused on the cross-sectional area measurement of peripheral veins with PIVCs for aspirating blood. Their recommendations were to use a cross-sectional area for vessel measurement because what they found that it impacted device functionality, particularly around blood aspiration from the device. The relationship between the vein diameter and the catheter diameter was a potential limit to blood flow around the PIVC. However, this did not address any catheter-associated thrombosis. Our publication from 2017 compared the traditional rule of thumb, or 33 to 45% rule of CVR against area-based calculations. Now, once again, the general rules were traditionally based on a single linear measurement, not focusing on area of the vessel. And one of our recommendations that we need to consider that a vessel is actually a three-dimensional object, meaning that it has height, width, depth, and volume, yet a lot of the measurements that are taken are in a two-dimensional perspective, particularly when we think of it from a lineal perspective. So for clinicians, one of the questions that came to us was that how do we make it simple and effective for clinicians to measure catheter vessel ratio? What is the way to simplify the process and make it quick and accurate? And one of the things that was determined was that we'd come up with a color scheme that was originally based on the zone insertion method by Rob Dawson, where you had a green, yellow, and a red zone, very similar to a traffic light. Green was safe to go, yellow was precautionary, and red was a no-go, so you had to stop, or it was high risk. And so we broke these down into areas of 33% or less, which was the green zone, which was safe, 34 to 44%, which was the cautionary zone, which means you can use this area, but you just have to make the necessary calculations that it's still going to be safe to use. And then there's the cutoff point of 45% or greater, which is the high risk zone, which is also recommended by INS, saying do not use anything higher than 45%. So based on the previous literature, we wanted to make it easier for clinicians to calculate their catheter vessel ratio. So how do we make a tool? Well, basically it's a calculator. It looks at mathematics. So CVR Calc was released several years ago, version 1, which was based around the INS standards. And admittedly, we used area and the INS standards sort of fairly loosely. But as we had more discussion with clinicians about what they wanted, and also what we wanted to achieve as far as doing an upgrade, we decided to release a newer version with an update that provides both a linear and area-based catheter vessel ratio measurement. So it gives clinicians the opportunity to choose their preferred method of measurement, whether it be in linear or whether it be in area. And that helps clinicians document a more appropriate catheter vessel ratio in their clinical documentation, which is important because when we're doing research on vascular access devices and thrombosis, catheter vessel ratio should be a common data point that is reported and recorded regularly so that we can get accurate assessment of appropriateness of catheter for the vessel. This recent publication by Rebecca Sharp and co-authors looking at catheter vessel ratio and risk of PICC-associated thrombus, according to Diagnostic Group, was a retrospective study that looked at a 45% catheter vessel ratio cutoff as a predictor for thrombosis, with findings that catheter vessel ratio greater than 45% had more than twice the risk of developing thrombosis. Now, there are no surprises here when we think about what we've talked about in previous literature. However, reverse taper peaks were not included in the data analysis, which may provide imprecise diameters to inform accurate catheter measure decision making. This is important because what it's talking about is just non-tapered catheters. So the potential risk that reverse taper catheters have, which we discussed in previous slides, may increase even further the potential risk of catheter-associated thrombosis. Interestingly, that patients that were on anticoagulant therapy, 0 patients had any catheter-associated thrombosis VTE, which emphasized that anticoagulants have an impact for patients that have central venous catheters or peripherally inserted central catheters and reduce their risk of CRT and VTE. 72% of the patients that developed catheter-associated thrombosis were patients that were receiving chemotherapy. So once again, it highlights that our cancer patient population was a high-risk group of individuals, whereas the use of a catheter vessel ratio less than 45 or equal to 45% and non-tapered PICCs should be considered to help minimize the risk of thrombosis. And this was one of the conclusions that the authors stated. So there is, once again, information that has been evaluated and analyzed through research that helps us as clinicians strategize ways that we can appropriate device use to try and reduce catheter-associated thrombosis. And that's maintaining a less than 45% catheter vessel ratio, the smaller the better, and using smaller external diameters of catheters. And that means using either a single lumen catheter over a double lumen catheter, depending on the type of therapy that needs to be administered, or making sure that we're choosing the most appropriate device based on vessel size and catheter availability for the type of treatment that is required. This abstract was published in 2023 in the Journal of General Internal Medicine as a conference abstract, evaluating 6,630 patients with PICCs looking at catheter vessel ratio for analysis. As you can see, they had a small number of patients had catheter vessel ratios greater than 45%, and about 93% of patients that maintained a catheter vessel ratio less than 45%. What they found was that complication rates were very similar between the two groups, and when stratified by catheter thickness, the rates of complications were quite similar between both groups with a non-statistical p-value. However, in this analysis, catheter vessel ratio greater than 45% was not associated with PICC-related catheter-related thrombosis or catheter occlusion. However, the authors did state that increasing catheter thickness was associated with a higher risk of VTE and catheter occlusion. Lastly, venous thromboembolism and PICCs and children. There was a recent study that was published in 2020, which was a multi-center prospective observational cohort study that was done over 5 years in the United States. The authors compared the incident rate and risk factors of CVC-related VTE in PICCs and tunneled catheters in children. Now, bear in mind that there's quite a significant difference even just in the design of these catheters, not to mention the materials that they're made from and the external diameter. However, the incidence of CVC-related venous thromboembolism was about 6%, and the majority of the patients, 80% of them had PICCs, which was a significantly higher risk of VTE than patients with tunnel catheters, which had a strong statistical significance, a p-value of 0.001. Children with PICCs also had significantly higher risk of CLABSI, 0.002, and CVC malfunction, 0.001, over tunnel catheters. So PICCs performed far less beneficially than tunnel catheters in this patient population. The author's takeaway was that children with a history of thrombosis, leukemia, or the use of a multi-lumen CVC have an increased risk of VTE, suggesting that clinicians take pause when deciding on to use a PICC over a tunnel catheter in particular patient groups of pediatric patients. This publication from 2024 was an interesting publication because it was looking at where we're at and where we're going, looking at the updates and ongoing unmet clinical needs in regards to catheter-related thrombosis. What the authors found and what they stated was that the management of catheter-associated thrombosis requires a careful balance between the risk of thrombus progression, recurrent events, and the systematic embolization and the increased risk of bleeding that's often associated with some of our more fragile patients like cancer patients or patients with end-stage renal disease. They did talk about oral anticoagulants is certainly being used more increasingly, and it represents an important alternative to the standard of care, which is low molecular weight heparin in selected patient population groups. The management of catheter-related thrombosis still remains challenging, it remains controversial, and local and systemic complications from either of the disease or its treatments are not negligible. So there are obviously still significant concerns, not only for the complication itself of venous thromboembolism or catheter-associated thrombus, but also in the treatment that is associated to try and treat these and prevent further complications from occurring. So despite the constant improvement in techniques and the materials to try and prevent catheter-associated thrombosis and the risks associated with this comorbidity, the incidence of catheter-associated thrombosis remains substantial and requires a lot more further investigation. In summary, looking at the evidence that has been put forth today, and look, this is a fairly small portion of the published literature that is actually available to clinicians when it comes to catheter-associated thrombosis and venous thromboembolism. There's a lot of information out there, but there's a common thread amongst all publications in that we still need to try and minimize thrombotic risks across all our patient groups. That's neonatal, pediatric, and adult. When it comes to vascular access, catheter size, the appropriate size of the vessel, and accurate patient assessment is still a high priority for all clinicians to be performing when they're making decisions about what is going to be the most appropriate vascular access device. And this is important not just for PICCs or CVCs, it's from everything from a PIV to an acute hemodialysis catheter or even chronic catheters. Thrombosis is a long-term problematic complication for patients, and once a thrombus has occurred, there's a 50% chance that a thrombus will occur for every successive device that a patient has. So this is an exponential increase in potential risk of catheter-associated thrombosis with the number of devices that patients have. Deep vein thrombosis in the upper extremity is often asymptomatic. However, there is obviously increasing reports of systematic complications being prevalent as well, but it is significantly lower risks than a lower extremity DVT, which has a higher risk of pulmonary embolism and atrial thrombus formation. Ultrasound is still considered the diagnostic gold standard, and all clinicians should be using ultrasound to their advantage, but also the patient advantage, and we should be monitoring for thrombus using ultrasound frequently, whether it be for a PIV looking at superficial thrombosis or more sinister thrombosis in the form of deep vein thrombosis or upper extremity deep vein thrombosis. I'd just like to say thank you to you all for attending today. I hope you enjoyed the session and that it was beneficial and it provided some information regarding catheter-associated thrombosis, catheter vessel ratio, and the impact that all of these have in our clinical decision-making processes as clinician, but also how we can try and impact for better and more positive patient outcomes. Thank you very much.